Also, our next CEU online is Tuesday, February 18th from 12 to 1 p.m., titled Customizing Medications for End-of-Life Care with Harry Zollers, the owner of Maryville Pharmacy. And you can sign up right now on hospice.org/events. I'm going to hand this over to Lisa now.
Thank you, Leah. And we just want to remind everybody, your CEs will be in your email by February 5th. We have, there's just a lot going on. We have our huge gala in Mary this weekend that Leah's involved with. So we just wanted to give her a little extra time, but you will have them by February 5th. If not, please do not hesitate to reach out to Leah or myself and we'll get it taken care of. Another change for this particular presentation with the state of Illinois, to receive CEs now, social workers have to answer 5 questions. So that will also be attached to the survey, correct, Leah? For the, oh, this is a
Yes,
social
there
worker.
will be two different surveys for you to click on. There'll be one specifically for social workers, and then the other one will be specifically for nurses.
And that's through the state. That's not a Hospice of Southern Illinois thing. So now that we have this housekeeping taken care of, we want to welcome Amy Brigham. And we also want to say, aren't we glad we're online today and nobody has to get out in their cars if they don't have to? So we want to welcome Amy. Amy is a dedicated nurse practitioner specializing in wound care, overseeing highly skilled team of nurse practitioners in post-acute care. As the director of clinical operations at Specialized Wound Management since 2004, she brings extensive experience to her role. Amy has held certification as a wound care specialist from the American Board of Wound Care Management for the past 18 years. With a career spanning for over 30 years, Amy's journey in healthcare began as a nurse assistant. She has seamlessly transitioned through various roles, including nurse practitioner, DON, MDS coordinator, care plans, floor nurse, and nurse assistant. Her passion lies in post-acute care, aiming to deliver advanced wound care directly to the bedside. Furthermore, she strives to establish partnerships with the communities they serve by fostering ongoing support and education for the nursing staff. Amy's commitment extends beyond the clinical responsibilities. She actively contributes to the field by writing and editing textbooks and journals, offering her expertise as a consultant and as an expert witness, participating in provider panels and delivering lectures nationwide on advanced wound care and related subjects. Amy, it's obvious that we're in good hands here on this topic. Thank you so much for joining us, and everyone sit back and we're about to learn something because I know every time I hear Amy, I learn something else. Thanks, Amy.
Well, thank you, Lisa, and thank you guys for joining today. I know everybody's busy and trying to come and join over your lunch hour. So I kind of was going through and putting this talk together. Let's talk skin, a little bit of everything. We're going to kind of talk about, what causes skin problems, how do we take care of them, and then most importantly to me is how we prevent them. I know that I'm a wound care nurse practitioner. People always ask, I'm like, I never go to bed at night and worry what I'm going to do in the morning. So the more we can all work together for prevention, I think the better off that everybody will be. And one of the most important things to realize is our aging skin. I mean, what happens as we age? Aging is a natural part of life, right? But it brings unique challenges, especially to the skin. It's one of the organs that we don't talk a whole lot about. And we're going to kind of go over that today. So, our skin tells the story of our lives. But as we age, it can undergo really significant changes. Understanding these changes are what's crucial for maintaining skin health and overall well being. I do feel like it's one of those areas in school that we probably don't get a lot of time spent on. I think it's kind of one of the things everybody takes for granted. And when our skin isn't working correctly, doesn't heal the same, all of a sudden everybody's kind of like, well, why? Because it's always that barrier that's there. So we're going to kind of go over that today as to why these things can happen, what you can do about them, and different ways that you can prevent areas from starting in the first place. So I got a whole slew of objectives here because you guys that know me know I had a whole lot to say when I was trying to narrow down what we were going to talk about today. So physiological changes, because I think that's important to know why we're seeing the things that we're seeing, understanding, what happens to that skin. It becomes thinner, less elastic, why it's more prone to injury. Common risk factors, especially in the elderly population. And one of the things I think to realize is there's a lot that goes into the skin. It's our biggest organ, and a lot of things that are going on with your patients, or if it's you in particular that, is on this call trying to learn more, immobility, incontinence, nutrition, all of the chronic conditions that we kind of can see as we age will play an underlying role. And we're going to talk about that today. What are the ways that we can detect early skin breakdown? What are some of the ways that we can use for preventative strategies? And then just overall understanding the role of caregivers and healthcare providers and what a big difference everybody can make by just doing a few things. And you're going to hear me say a couple times today is if you see something, say something, because I think that's the biggest thing is we see a lot of patients that all of a sudden end up with an area and nobody really understands where it came from. Nobody thinks it's a big deal at first, but um, just wounds in general, one of the statistics out there, diabetic foot ulcers, when a wound starts, the first 4 weeks is the most important. If they're not healed within 50% within the first 4 weeks, we know they're a lot less likely to be closed within 12 weeks. And that goes for, a lot of other types of ulcers and wounds that can occur. The longer that they're open, the harder they become to heal. So I think it's one of those things we don't want to sit back and watch and wait and hope it heals and then think, oh, we'll do something, 2 or 3 or 4 weeks from now, because it's really the most important thing is right off the bat when they first happen. That's our biggest opportunity to get them to heal. And, me and Lisa were kind of chatting before we hopped on the call here. And one of the things that is my important thing to talk about this year is getting people to really understand, we have 11 organ systems in the body, 11 major organ systems. The skin is our biggest organ. And I don't think people often realize or think of the skin as being in that subset of organs. And it really can be very impactful as we age, as people get older. And I think it's important to understand that when we start to have skin breakdown, it can really impair somebody's quality of life from a painful situation, from a dignity standpoint. People become socially isolated. They don't want to go out if they have a wound, it's not healing. Maybe they've got bandages, maybe there's an odor. And so I think it's really important to kind of understand what causes some of these wounds to start and know that there is a lot of stuff we could do to prevent them from getting to the position that they are to be causing that much of a quality of life concern. And as caregivers, we really hold the key to that. The more we know, the more we can do to help our patients. So, I kind of looked at Mabel here, and I get so many patients that come in and they say, you know what, it happened so quick. And one of the first questions I ask is, how long has this wound been here? And people will say, a week, 2 weeks, 2 years, 5 years. Early off in my career, I had someone once tell me 15 years she had lower extremity ulcers prior to me starting to see her. And a lot of times people don't realize as we get older when those wounds start, and then, they don't heal as fast as they used to. And kind of going back to if we don't take care of them right up front, that's when we can start to run into these areas that become chronic skin areas that don't, go on to healing. And why is that? Why doesn't our skin heal like it did initially when we were younger? So a couple physiological changes that happen, right? The outer layer of the skin, we've got epidermis, dermis, subcutaneous tissue, muscles, tendons, ligaments, bone. And when I come in and I see a wound, the first thing I'm looking at is what layer, what's the depth of the tissue destruction that we're looking at. So one of the most important things to realize is when you look at your epidermis, your outer layer, that's really your protective layer. Well, as we age, that continues to thin. As it thins, it's going to make it more susceptible to us having injuries there. And then subsequently, the next thing that happens is we get a loss of elasticity. I mean, we all know that in our face and our neck, skin loses its ability to stretch and bounce back, right? Well, the same thing happens when you bump it, and people will tell me a lot of times, I just, bumped into the car door. I just bumped into the side of the door frame. Um, I was sick for a short period of time and spent, a week in bed, and all of a sudden I end up with a bed sore. So as our aging skin just becomes more fragile in general, that we're really looking at. And, kind of looking at just thinking about your skin as a garden as we get older. Aging skin resembles that garden. Well, as we start to have skin that is going to be thinner and we're not going to continue and keep that moisture balance that we had before, there's a lot of things that we can do to keep that skin more hydrated, which increases the pliability as we kind of move through those phases of life. And so when we kind of look at and dig a little bit deeper into some of the physiological changes, skin thinning occurs because that epidermis, that outer layer, becomes thinner. Well, then what happens is that dermis becomes exposed a lot quicker. When we have dermis exposure into the environment, that's what's going to lead us to, having more chances of infections, injuries from, starting to happen. Well, one of the things that happens then is we kind of looked at that elasticity is, right, our collagen deposition is not working quite as well as it was before. We're losing that elasticity, and our fibroblasts, our keratinocytes are not regenerating at the level that they did, when we were much younger in life. So as that all happens, the other thing that we tend to see is the skin's ability to retain moisture diminishes. And I think it's really important this time of year. One of my patients I saw this morning, when I went to see her, well, more than one, I think there was probably at least three this morning, that I went and pulled some Cetaphil out of the cart and really lotioned up their lower extremities, their toes, their heels, and we're going to kind of look at here a perfect picture of what happens is when we see, and looking at my skin, and my hand looks like this today because it is so dry. As that skin starts to dry out and we don't keep it moisturized correctly, that's where we start to get these little fissures within our skin bed. And when we do that, and that's why I'm constantly preaching two things. Two things is, if you have a patient that's incontinent, it's why it's so important that we take that last step. And I always say, when I was a CNA, when I was, 16, 17 in high school, there's so many things now that I would do differently if I had known the things, that we just weren't taught, is that extra step in pericare. You'll take someone to the bathroom, you clean, you dry them, you get them good new garments, but we miss that last step of putting that barrier cream on. Well, that barrier cream, when we have this dry skin, because when there's urine and feces sitting on it, you know what your skin starts to look like. If we don't create that nice barrier on the skin, if we're taking a little lady to the bathroom, we stand her up to put her back in her chair, chances are she's probably going to urinate again. And now she's going to have urine, in her depends for another hour and a half or 2 hours until we take her back to the bathroom. Well, this kind of shows you when you get that barrier on there, you're protecting that dermal layer, that epidermal layer of skin, because now you can see with these cracks in here, our epidermal layer is now tarnished. And now we have access into the dermal layer with the urine and feces. The other thing that I think is super important to realize is arms and legs. One of the biggest things, and I have later in the deck, is the International Skin Care Association panel. And I gave you the resource and the website if you want to go out and learn a little bit more. It's well known is if we keep our skin hydrated and we bump it, it's a lot more pliable and it's going to have a little more elasticity to it. Once skin becomes dry, especially in this environment with the furnaces running like we are, and we bump that arm, all of a sudden it's going to be much more likely to split open. So why it's so important, arms and legs, is to keep that, the Cetaphil, the Eucerin, a non-perfumed ointment as a hydrating surface. And then for anyone that's incontinent, to really utilize those barrier creams, because that's where we're going to get this protective layer. I don't think I can say that enough. And I think about, Evelyn here, as we used as a little example of patients that I see and take care of. And I still do this 30 years in. I'll walk in and you're always looking at how old somebody is. And I'll look at them and it says, oh, they're 97. And I'm like, oh my gosh, she looks like she's 76, if I would have had to guess. And I always will say, what's your secret? Like, oh my gosh, your skin's so beautiful. And you kind of go through and you look at the different things that we can do over the years of our life. So I thought, for all of us that are on here as caregivers, because I think it's a big proponent that we take care of ourselves in order to be able to, keep our cups half full and be able to take care of the patients every day, is I had to put a little slide in here for tips for healthier skin as you age, so that you don't have these problems. My friends will laugh at me and they say that I act like I'm 90 sometimes because I have the hat on when we go in the sun and I have the sunblock on, and not related to the sun, but I wear my compression stockings every day to work because I want to have venous ulcers when I get older. So just a little tidbit here is sunscreen, even hydration and healthy diet. Your skin cells are constantly regenerating, right? We all learn mitosis. One cell splits into two, two splits into four. How do you think those cells are regenerated? They're regenerated by what we eat and drink. So if we're putting crap in our bodies all day, what's going to happen is the cells that are regenerating, our skin's not going to be as healthy. And you're going to see that down the road as people age. Manage your stress levels. Smoking, I can tell a smoker when I walk in the room. And that, face, arms, legs definitely impacts the skin later in life, makes your skin much thinner. Moisturizing with your lotion, and then, of course, checking your skin for any type of dermatological skin cancers that may be showing up, and people are, seeing that younger and younger every day. So that was my one little tidbit for everybody on the call today, is to kind of take a little bit something back for yourselves. But so us going in as caregivers, teamwork, I think it's really important to understand is this is really a multidisciplinary approach to skin. This isn't something I do on my own. This isn't something the CNA does by themselves. This isn't something the floor nurse does. This is something that we really have to take a step back, and we're going to talk about all the underlying comorbidities and different things that will affect that skin that maybe we don't realize. So from a multidisciplinary standpoint, I can't say it enough, is to bring your therapy in. PT and OT are just instrumental in helping us with getting that positioning, the offloading surfaces, the offloading devices. They can do wheelchair positioning, bed positioning. They teach our patients a lot. The other thing to bring in is speech. If somebody's not eating well, if they're not hydrating well, is to bring the speech therapist in. Is it a functional problem? Is it an anatomical problem? Do we have problems just with our denture? Sometimes it's simple things that will make a difference, if somebody's not eating or drinking well. And when we look at bringing in our providers, there's a lot of patients that, maybe are on certain medications we're kind of look at as well. You guys will see me sometimes. Even I had a conversation with a patient this morning about rearranging his room because he's, laying in his bed and he's watching TV and he's got a sore on the side where he's laying on. I'm like, well, what if we, move the foot of the bed over here, we move the TV over here, and this would give you a little different position. So there's just a lot of things that you can think about, and we're going to kind of go through different preventative devices too as we talk, but just knowing that this isn't just a nursing thing. This is something that we all really should work together on in our field. So what are some of the early detection techniques? The biggest one is visual inspection. And I think it's one of those things, and I will preach this all the time to the CNAs I work with, is you just should get in the habit. If you take someone's socks off, you should always be checking their heels. If you take someone to the bathroom, you should always be looking at that sacrum and ischial bones. One of the things that I notice is when I go in and I start to look at somebody, sacral ulcers generally come from somebody laying in bed or in a recliner. Ischial ulcers generally come from someone who sits up too much. And so little tidbits of things like that, when you know their environment, their behaviors, there's things that you should kind of always think about. But doing that constant visual inspection and knowing at the first sign of a problem is to bring that up and let somebody know, like, hey, there's a little red area here, or, we may be getting a little warmth or swelling there, is that then we can look at what the underlying cause is. Because I tell people it's not all about the product you put on. If you don't fix what the problem of the cause was, we're not going to get the ulcer or the wound to heal or prevent it from continuing to deteriorate. So palpation, I always ask people, like, is it warm? Is it hard when you feel it? And then documentation is to know where you started at. And I was on vacation last week. And so, I had a couple new patients today that I hadn't seen last week. And I actually asked one of the patients, his daughter was in there, and I said, have you seen this? And she said, yeah. I said, would you mind looking at it and tell me if it looks better or it looks worse? And so that's instrumental. A lot of times if somebody has a cellulitis, or if there's something I'm, looking at where there's an area of redness or warmth, I'll take a Sharpie and just outline it. It's a great visual indicator for somebody coming behind you to instantly know if it's outside of that line, it's getting worse. If it's coming inside the lines, we know it's getting better. So just a way to document. And then of course, taking measurements of a wound is a nice objective way to know if something's getting better or staying the same, or maybe even getting worse, that you can make some changes for that patient. Common causes of skin breakdown. This is, one of the things of really looking outside that box. Immobility causes prolonged pressure, can lead to ulcers. We're going to talk about chronic conditions and how they can impair your skin in general. Patients with poor nutrition and dehydration for various reasons. And I think a lot of people don't realize medications. I have a lot of patients that I'll see that have been on long-term steroids where maybe they had some eczema or they had a rash at some point, and some well-meaning provider had given them a steroid cream that they had been using for a long time. Steroid creams are great to, you know, be a short-term solution to solve a problem, but when we use them for extended periods of time, they will overall thin that epidermal layer of skin. Patients that have been on cancer treatments, obviously, that outweighs the risk versus the benefit, but it's just something to be aware of when you're looking at someone and taking a good history on what the cause was. NSAIDs, I think sometimes in our society, we are quick to pop an ibuprofen or Tylenol. And so I think the NSAIDs in general is people need to realize like they really do have some risk for them. It's not something that we should just be, inadvertently popping. It's really getting to the root cause of why we need the NSAIDs and trying to alleviate the pain or discomfort that someone is having. Patients that take anticoagulants, a lot of times if I see someone that has a blood blister on a heel, or something pop up and I see that they're on some Coumadin, instantly I'm going to go back and look at that INR level. Is our INR up? And is that why, we're starting to see um, these kind of ulcers develop? And then immunosuppressants. So I didn't put an additional slide in on the medication, so I just kind of wanted to go over them a little bit. This is one of my patients, John, I put on here as bells and whistles. When I come in a room or I go to, see somebody and there's no bed and I find out they're sleeping in a recliner chair and they've got an ulcer on their sacrum, I immediately know that, we're probably both in a little bit of trouble here. So because they're never fully offloading. And I think, when you look at patients that maybe have a new stroke, somebody that's congestive heart failure and is just wore out, and we kind of think about how mobile are they. I found this graphic that I pulled down from Dalhousie University that I thought was really interesting. It kind of goes through its geriatric medicine research, and they scored frailty because I think as a population, sometimes we feel we've gotten really, really good at keeping chronically ill people semi-well. And by the time they come into a facility of some sort, patients are sicker than I've ever seen them before. Patients that used to be in a skilled nursing are most likely in an assisted living at this point. A lot of people are still in the home setting that maybe years ago would have been in assisted living or would have been in a SNF. And when you kind of looking at an elderly person and you start looking at where's their activity level and where's their frailty, you can kind of see here with the cane, we're pretty vulnerable at this point. Well, not dependent on others for daily help, but symptoms of their chronic diseases will often limit their activities. And that's where that's less mobility than what they were using and up and beforehand. Mildly frail, when we started to get moderately frail, somebody that needs help with all outside activities. I mean, they maybe can move about their room, or if it's their house, maybe can, make themselves food, can go to the bathroom, can, provide a bath and a shower, but they're not going out of the house to get that food. They can do their medications, but someone has to bring the medications to them. And then, severely frail, completely dependent for personal care. I mean, that's a lot of patients that are coming into a skilled nursing facility today. And then you'll see down here on the right is scoring people with dementia because they may be up and walking quite a bit, but then they may also not be able to provide those personal care details for themselves. So we're going to I got a little, some charts on that, is just thinking about that maybe a little differently than what you've always thought of in the past of, we have the ADL problem, which causes the ulcers, but really there was something that happened before we had the ADL problem initiate. So, one of the things to kind of think about is, and I always talk about my patient as the host. When I come in for a new visit and I'm looking at a patient and, they say, oh, so-and-so either was admitted or developed an ulcer or a wound or a skin tear. Doesn't matter what it is, any type of skin condition, it doesn't always have to be a pressure ulcer. I saw somebody today with an ulcer on their heel. Pretty sure they don't have any blood flow, walking in the door, because immediately I'm looking, I'm like, okay, he doesn't have any hair growth on his legs. His toes are kind of cool. There's just different signs and symptoms. And so when I walk into the door, what I'm automatically doing is seeing how healthy is my host, because you got to go back to the skin is my biggest organ. And if I have other underlying organs that are not functioning correctly, I'm going to have problems getting my skin to heal and stay healed. And so
A-
that's something that we all have to be aware of.
Amy, I do have a question in the chat. Would you like that now, or do you want to wait till the
Sure.
end? Okay. Do you have any specific type of moisturizer that you prefer? She works in oncology and radiation for a radiation doctor who wants no, is it paraffin in the products her patients use? Thoughts?
Paraffin. And usually what I will recommend is, and I'm trying to think if there's paraffin in them, is my general rule of thumb is like a Eucerin or a Cetaphil. Are, generally Vanicream is another one that I really like for patients, but nothing that has any type of perfume in it. And I think that's an important thing for them to understand is, people are so feel like, oh, I'm going to bring in that Bath and Body Works for grandma, or I'm going to bring in this scented thing. And I think that's where we kind of go wrong is we really need to keep those products that are, hypoallergenic and don't have any extra things in them. And honestly, I've never looked at it as paraffin, but I'm gonna have to go and look later today on those products. But generally, Cetaphil and Eucerin are the ones. The Vanicream I really like as well.
And another question that came in is Aquaphor a good skin barrier?
Aquaphor. Sometimes Aquaphor is going to trap moisture, so we have to be careful with. It's not something that I generally will see utilized as a barrier for incontinent cream. Um, just because of the emollient, the way it works on there is something that, I see a lot in the dermatology offices, but Aquaphor is not something that I see utilized for skin prevention. I see it utilized more when there's already maybe a procedure that's been done or they're utilizing the Aquaphor for more of a moisture balance type of a piece.
Okay. That's all so far. Thanks so much, Amy.
No problem. So we kind of look at the host here. Like I said, I'm looking at how healthy is my host? And when I start going through that past medical history, when I first started as an NP 20 years ago, is, I might have 6 or 8 ICD-10s. When I go to see a patient today, most of my patients are going to have 35 to 40. And when we start looking at organs, I always think about my major organs, right? Heart disease, congestive heart failure. How many different ailments do you have that involve the heart? A lot today. How many patients have had a cancer diagnosis at some point in time and undergone treatment? Chronic lung diseases, COPD is a big one. Patients that have had a stroke, we start to see affected sides. Alzheimer's and dementia patients, there's going to be a lot of changes there from mobility, ADLs, as they get more into advanced stages of life, they're, no longer going to be having the need to eat and drink like we used to. And that's really hard, I think, for some people to see and understand. But when I look at an Alzheimer's patient as someone that normally was walking around, all of a sudden needs a walker, then they need a wheelchair, and then we might be in one of those recliner chairs, as we really kind of start to see not only is, the brain, but we have other organs that are not functioning the way they were either. Lots of diabetes. It's not something that was well understood 20 or 30 years ago, and we're really feeling that in this population today. Patients with chronic kidney disease, a lot of people don't realize we have 5 stages of chronic kidney disease. And so, many people will say, and I got some labs in here that I'm going to show you, is mom or dad comes in and they're like, well, the doctor said they were doing good. I'm like, well, they are doing good for someone in their 90s that has congestive heart failure and has chronic kidney disease and, maybe has a little underlying COPD. And so when you kind of go through and you look at all of the things that are going on at this age and point in time, we can start to see why we have problems with the skin developing and then also, healing once we do have those open areas. So liver failure, we have a lot of fatty liver that I see nowadays. And then issues with digestion in general. And, the jury's still out as far as the gut microbiome and everything we're doing as a society from that standpoint. But there's going to be more research that comes out, I think, from that angle as well. And so, when you kind of go back to, and I say the skin's our biggest organ, we think back to what have we always known? When somebody's in that ICU setting and we have acute skin failure, Because what happens if they're in, near life or death, we have to give them vasopressors. What happens? I see a lot of patients that have black fingers, black toes that come out of that ICU type environment because we've got all the blood coming into the core. And this is our main subset. So the body is always going to pull in order to make sure the heart, the lungs, the kidneys, the liver, that all of these organs in our core are continuing to function properly. And so when we think about that, with the patients that we're taking care of, there's really three types of skin failure. There's acute skin failure, which we're all very well aware of. There's end of life terminal skin failure when, somebody is actively phased, actively passing and their organs are shutting down. Maybe a couple days or a week before that they're going to pass away, the body's going to start, shuttling that perfusion in, and we're going to start to see skin breakdown in certain places. But one of the areas that's really come to light, and there's been a lot of research on, is chronic skin failure. Chronic skin failure, and the definition of this is two or more organs in failure. So when you think about an elderly patient that a lot of us are taking care of today, not our 65, 75-year-olds that are living in the community and out, driving and doing all of those things, they go into the hospital with an acute medical condition. They've got an underlying, health history with some of these organs and having issue. I think the statistic says 65% of patients over the age of 70 generally will have two or more organs showing like they're not functioning at full capacity today. So when they have that acute medical illness, they end up in that hospital setting with an underlying comorbidity to go in conjunction, that's when we start to see these skin areas pop up. And then, patients that are in that more assisted living, SNF type of setting, or maybe living at home, but they're functioning in the house, but not really getting outside of the house a whole lot. When we look at those patients and they have 3, 4, 5 organs that, are not functioning at their full capacity, that's when we start to see the skin breakdown because the body's only going to have so much reserve. And that's, one of the things we're going to kind of look at here. So when we see these early signs of skin damage, this is a perfect scenario of when you see something like this, I always look at this as a warning sign. And, even NPIAP, National Pressure Injury Advisory Panel, came out and changed our staging back in 2017 and said that, a stage 1 is a sign of an at-risk patient. There's so many times if we can get a hold of this and we can offload them or we can change, something that's going on the trajectory of their current environment or life, at that point, we can maybe eliminate this and prevent this from actually becoming an ulcer that opens up and progresses. Now, some patients, we may not be able to. So kind of just to put this in perspective, when I come in and I see a patient, you'll see in the center here, this wound ulcer is just one small piece of everything that I'm going to look at with these patients. And so when I come in, there's so much more that you're thinking about when you're looking at somebody's skin. The history is a huge component. So my actual physical exam is the wound and ulcer, but how old are they? Because I know that's going to impact the skin that I'm trying to heal and work with. What do their vitals look like? Have they lost any weight? We see a lot of patients with chronic illnesses where they don't really see them as losing weight, but when I pull up like hospital records from the last couple years, I'll see this slow decline. That is a big indicator of, at this point we've depleted nutritional stores and we're not giving ourselves the nutrition and the energy we need to maintain our skin. The full physical exam, that's pretty basic. And then how compliant are they? Um, Lisa knows I'm a big proponent of, quality of life versus quantity of life. And I think that's one of the things, and I tell people all the time, I'm like, look, here's the perfect textbook answer. And I had one of my patients tell me today, I wanted to move his bed. And he was like, no, like, I absolutely don't want it moved. I'm like, okay. He goes, what do you mean, okay? And I said, okay, I'm not going to move it. Like, it's your decision, but it's my job to educate you and explain like why I think this is a good idea or why this would be helpful. But you're in charge here. And if you don't want to move the bed, we're not going to move the bed. He was like, really? So it's just a matter of documenting some of that stuff too and trying to, continue to work with them and find that common ground of what can we do. And sometimes, we maybe will take one answer that maybe wasn't the best, but for that patient, maybe it was really the best quality of life for that moment. Diagnostics that are out there, we're going to talk about labs a little bit. If I've got wounds and ulcers on the trunk, I'm looking at their support surfaces. Lower extremities, and this is one of the big things that I see all the time. If you have a wound on the lower extremity, if I bump my foot on the side of my foot, I get a bruise. It turns green, it yellow, it goes away. Somebody that bumps their foot that doesn't have good arterial blood flow, that bruise is not going to turn green or yellow because there's no blood getting down there. The blood brings the oxygen, the nutrients to rejuvenate the tissue. That bruise now turns black. That's how people end up with these ulcers that then become gangrenous. They end up with amputations. So lower extremity ulcers, at the first sign of any kind of wound or ulcer on a lower extremity of somebody that's of advanced age, we need to get further testing to know what the blood flow looks like. Um, because then we can make different decisions. Like, do we want to go to vascular surgery? Do we not want to go to vascular surgery? There's a lot that can impair this plan of care. And that's one of my big things too, is I think we have to really discuss the goals of care. Just because, I can tell you the textbook goal, but what is the patient's goal? Sometimes they don't want to go to more doctors. They don't want to have more procedures. But we need to have those conversations early, not when we're at the point where it's like, okay, now we have, this extremity that needs amputation. So same thing with sensation. People that have neuropathy is a very big thing with our diabetic population today. And then a lot of patients that have, um, neuropathy of other origins in the older population, and especially I feel like I see in like Southern Illinois more so that we have a lot of a farming community. We have people that spend a lot of time on their feet, and a lot of them have just literally worn out their lower extremities on a lot of levels. I put in here some labs, just something to kind of be aware of. I look at, A1Cs, albumins, proteins, C-reactive proteins and ESRs are kind of difficult in this population if you don't know where you started, but just to be aware of, it's an inflammatory marker. It is going to affect wound healing. Hemoglobin and hematocrit. A normal hemoglobin is around 15. Very few of my patients that I see on a daily basis are going to have a hemoglobin at that level. The hemoglobin pushes the oxygen and the nutrients. And so if we have fewer cells of hemoglobin in our body, then we know that we're not going to push the oxygen and nutrients that we need to get to the sites for healing. So that all kind of becomes a trajectory. Well, then all of a sudden, if we have someone who has a little compromised lung status and their oxygen isn't perfusing to start with, we don't have enough hemoglobin, you can start to see where we really run into problems with getting some of these patients to heal. Vitamin D levels is going to affect dryness and fragility of the skin. There's a lot of research out there on vitamin D. Renal function tests, I kind of mentioned earlier, there's multiple stages of kidney disease. I a lot of times will pull out my labs with the patient or their loved ones and say, okay, here's where we're at. And they'll say, well, the doctor said they were doing pretty good. Last I just went to the primary care doctor and they said we were doing pretty good. And I'm like, he is doing really good for someone who's 87 and has congestive heart failure. So when you start to look at these like labs, when I start looking at all the organs that are failing, so congestive heart failure in the heart, right? The pancreas is failing because our glucose is elevated, right? We look at our GFRs, our kidneys are failing. When we start to look at our albumin, right? So we have protein calorie malnutrition. When we start to look at the hemoglobin is 8.5, and we start to go through all this stuff, the patient's diabetic. So, they've got neuropathy, their nervous system isn't working well, their peripheral vascular system isn't working well. So they've got a lower extremity ulcer and they don't have good perfusion. Well, the skin is just this organ in this host of problems that we have. And when you kind of sit down, you start looking at it, it's a different conversation because sometimes, I'll have a lot of people that, nobody wants to have that conversation with their loved one. And it's like, it's okay. And I ask a lot of patients, I'm like, what do you want to do? Do you want to go see more doctors? Like, do you want to go to the hospital? Some of them like, yeah, like they give me three answers. Yep, I want to do everything I can. I'm not really sure. Let's get the testing and see what it looks like. Or no, I don't want to go and be out, schlepping around and going to doctor's appointments and being poked and prodded and stuck. But that's the key is is to have that conversation. And then maybe if the patient doesn't want to have it with their power of attorney, or sometimes the power of attorney doesn't want to have with the patient, a lot of times, I kind of create that liaison as well. So just something to kind of be aware of. We have tools that are out there that you can utilize to go through and really look at. The brain is a standard of care that's been around for years and years and years, underutilized tool. As a nurse, I'm going to tell you, some of you guys on here are probably going to smile. The first the Braden, everybody else copies it pulling forward, right? Well, the population that we're taking care of, a lot of them are probably not staying the same or getting better. And so you'll look 3, 4 years down the road and the Braden's still the same. This really can kind of shed light on the areas you need to focus on. So, if someone has sensory perception issues, then we need to know that we really need to protect their feet. Make sure they're not bumping them, because if they do bump them, that's when we're likely to get those black spots to show up. If they're, someone that has a stroke, we may need to, augment their wheelchair, their devices that they have. Moisture, we need to be really conscientious about getting that barrier cream on. Somebody that has mobility or activity issues, somebody that has nutrition, have we had speech see them, sometimes we can use appetite stimulants, but the one thing I think to be aware of, and the one thing that people need to understand is, a lot of times they're like, well, like we can put in a tube feeding, or, they're like, well, can't you put in a tube feeding or put in an IV? We get to some points in time in our life where the body is just not going to metabolize those nutrients and take them and do what it needs to do with them. So you're putting stuff in, and either the body's just dumping it, or they're accumulating excess fluid because the heart and the lungs, and it can't be processed. So just something to think about. There's a lot of options here, but we got to make an educated decision based on other confounding factors that that patient might have. This is a form that I had, come up with over the years, and a lot of facilities will kind of use it as a care planning tool. As a patient comes in, you can look at and check off all the problems that patient has, and then you can utilize this to really focus on those areas. And now you've got a care plan for each of those areas. So, and even like tobacco use, if somebody is smoking, again, do I think that they need to, cessate? No, but it's up to us as healthcare providers to have that conversation with them. Once we have that conversation, we can care plan for it. Like, this is where we're at. Someone that's anemic, if they've been worked up for anemia, if they're taking iron, is to be aware of that problem and understand how it might impact someone that could potentially have skin breakdown, or if they do have skin breakdown, maybe not healing as well. But these are just, the most common reasons that I kind of see that could impact wound healing. This is kind of what I was talking about earlier. So when we taking this from a flip side, I feel like what we do is we focus on these functional limitations in the ADLs. Somebody doesn't eat well, somebody isn't able to bathe themselves, somebody isn't able to dress themselves, they're incontinent, they're non-ambulatory, they're sitting in a wheelchair. And we're like, well, that's why their skin breaks down. I mean, that's the functional reason why the skin is broken down, but what we need to do is take this a step back and look at if there's someone that has, brain, Alzheimer's, dementia, that's why they're not eating well. That's why they're not, able to bathe themselves. That's why they're becoming incontinent. And really look at that from, if we can look at those serious illnesses as we can watch them move through those phases, then we can see that, hey, because I'll come in and I'll look at someone that's been living somewhere for 2 or 3 or 4 years, and all of a sudden they're developing skin breakdown. When I go look at that patient, like, did somebody stop taking them to the bathroom? Did somebody stop putting barrier cream on them? No, what happened is one of their chronic medical conditions has now, progressed. They've lost weight. Usually there's one or two things going on at the same time where you start to see that skin breakdown, or you have a patient that had like an acute medical chain of condition of some sort. So that's where, when we look at these tissue problems that start, is, how we can really look at taking care of these patients to take that to a different trajectory. So, one of these, I kind of talked about the acute skin failure. We talked about, end of life skin failure. And then we kind of have this chronic skin failure, which falls somewhere in the middle where we start to see things present. But I just want to show you guys these pictures. Is when you look at these wounds here, you're thinking these are superficial. They're pretty clean, right? But if you take a look and you kind of look out from where the wounds are, you can see the peri-wound damage. This is a week later, 3 weeks in, 4 weeks with this patient. Somebody can do everything right, but if somebody's skin is in failure because their other organs are not functioning properly, that skin can continue to decline. And you can see just how rapidly it declines. So I just like to put this up there as something to kind of be aware of that, can happen. Hydration and nutrition. I kind of touched on this a little bit earlier. Speech therapy, always. You can look at appetite stimulants, but sometimes, I have patients where they're getting a patient a couple weeks ago and she's getting power pudding and she's getting this and that and this and that. And when you look at that patient, it's like, okay, we're dumping all this in. She's obviously not absorbing it. So it's something that we just kind of need to be aware of. Caregivers and healthcare providers, there's so much that we can do. You guys can kind of see. I put assessment criteria in here. Watch for signs like redness, swelling, blisters, and then, really look for the interventions of those early signs. I couldn't do a presentation today without putting in the ISTAP I mentioned earlier. When I see partial flap skin tears like this, I just want everybody on the call to be aware of is, wash your hands, get a good clean pair of gloves, get that skin wet. And if you can straighten that back out, that's your epidermal layer. And the research that's been done by the International Skin Tear Advisory Panel has shown us that if we can then replace that, even if the whole flap of skin is not there, what you can replace a lot of times will adhere. So this is one of my patients that had fallen out of bed through the night. I came to see him, it's been about 5 hours. So this was kind of drying up a little bit. And I used Q-tips here, but I do this every day. So if you need to get your fingers and, actually smooth that skin out, you can kind of see I finally got it to work all the way back over top here. And then I put a dressing on it. Now, if you're in an institution, you can use a dressing like this. If you're at home, you can use a big Band-Aid. But the key is to put this arrow at the bottom because now I know which direction my flap goes. I left this on for a week. That's what ISTAP says. You can put a foam dressing on, you can leave it on for a week. Some people will put zero form underneath. You make sure that you pull off from that bottom right corner because I want to pull in the direction of the skin flap. I don't want to pull that flap back off. Here's what this patient looked like a week later when I took the dressing off. All of that had re-adhered. And I didn't even have to put a dressing back on him. So just something that's out there. If you want to learn more about it, and it's free. You'll go on and they'll want you to create an account, but it's all free. Prevention products to be aware of. I think it's important to note to teach people of, when you're in the hospital, when you're in a facility of some sort, the mattresses that they're on, all mattresses in these type of settings are offloading pressure reduction mattresses. They're not the same mattress like we're going to buy down the road at, Lazy Boy Furniture. So I think that's something to understand is people don't realize in the community sometimes of all of the skin things and all the prevention that you guys are doing. And I think it's important, in the hospital setting, in the facility setting, even if you're doing home health care when you come in, is to kind of just talk about a lot of this stuff. They don't understand the importance of this barrier cream. And they don't understand that you've got 5 different choices of products a lot of times with your different lines that you may use with, the major product vendors that are out there, and they're all do a specific thing. We're going to look at some chair cushions, heel protectors. I didn't put a whole lot in here about nutritional products, but no, there's all kinds of extra protein and products that can be out there. I'm a proponent of getting the dietitian involved in this because people do have kidney issues at this age and stage in the game. Congestive heart failure, we want to make sure what we're giving them additionally is not actually causing any further problems. Incontinence products that are out there. These are not the same Depends like we used 20 years ago, or people may have thought and that are coming out in the lay public that they used with their kids. These are wicking products that are going to wick that skin away, and for them to understand that you've got a whole system you're utilizing. I like to teach people to micro shift, whether it's acute or chronic illnesses. If you're sitting in a chair, I tell them all the time, if you put some pressure and you sit someone in a chair, you can look, if I got my finger here for 10 seconds, I pull my finger off and that skin goes from white to pink. That's because I've closed the capillary pressure of the vessels moving through that specific space of skin. Once you move them, if you set them and you let them sit there for 2 or 3 hours, instantly that skin is becoming white and you've closed off the blood flow to that specific pressure point they're sitting on. So just a simple micro shift with people, whether they can do it themselves or you do it for them, can make a big difference in preventing skin breakdown. People that want to sit with the head of the bed up all the time. Huge bells and flags. If someone's on oxygen and I go in and I see them want to sit with the head of the bed up, look at the different pressure gradients that you're getting as you move that head of bed, elevate it. And sometimes, you can't, like, from a quality of life standpoint, we're not going to lower the head of their bed. But I think as healthcare professionals, we want to be aware of this and, have that conversation, see if there's some other way that we can change that trajectory. Cushion inflations, this is one of my soapboxes. It's not if they're going to deflate, it's when. We can't put these cushions and these beds on these surfaces and never go back and check them because they are going to be flat and you're going to end up causing more problems. So a couple simple steps is you put the patient in the cushion. You can slide your fingers between the bottom of the chair and underneath the cushion. You should be able to move your fingers about a half an inch or an inch. If they're sitting on top of you, you know it's underinflated. If you can't move it at all, you know it's overinflated. So just something to be aware of. Beds. I come in all day long looking at these beds we're spending a fortune on, whether we bought them or we're renting them. Alternating air beds, you can see these baffles in here. The whole purpose of these is to alternate that air so you eliminate that white pressure point. If you've got these beds on static, you're defeating the purpose of them. Static is for someone's meant to get in and out of the bed. Then we need to get them on alternate. I don't know if when the power goes out, they reset, but I spend all day long walking around, resetting these beds to alternate and locking them again. So that's a super important thing to watch. Wedges, the top here is a wedge for prevention. If we've got someone that has actual skin breakdown, we want to wedge above and below the wound. We don't want to wedge right into the wound. So I think that's another piece that I just was something I've never was taught in my earlier, stages of CNA life. These offloading boots that we have out, super important when you get the feet in them is to actually feel to see if that heel is offloaded. As they start to get older and that fabric breaks down, all of a sudden these heels are sitting right on the bed. With these offloading devices, the heels up cushions. One thing is just to mention and explain to the patients, the families, anybody that'll listen. Everybody who wants to put their feet on the pillow or on the device is they don't understand the whole purpose is for the heel to hang off the edge. So that's just something to be aware of. And then, my homework for the day is if you see something, say something. There's so many things that can be done to prevent from people getting into them situations where they have to have painful skin breakdown, areas that aren't healing. And what kind of questions do we have? I put up here my email address, my cell phone, if anybody has any questions, um, you know,
I
down
am
the road.
taking a look. No, we've got a couple of people saying this was great information. So that's a very good thing to hear, Amy. I'm not a clinician and I learn something every time I hear you speak. So does anyone have any questions? You can put them in the chat or right here. You did the other two folks that you answered the questions, they both said thank you. Amy, I don't think, and obviously, folks, her information is right here. If you think of something in just a bit, you could obviously email her. Amy, thank you. I really think from someone that isn't a clinician but reminding us our skin is an organ and it's aging. As I look at this silly bruise on my hand, Amy.
Lisa's really concerned, guys.
Yes, I don't like this aging bruise. So, anyway, Amy, thank you so much for your time. Obviously, you're busy and we appreciate it. To all of you on the call, thank you so much for joining us today. We appreciate you knowing Hospice of Southern Illinois is looking to support you in other ways outside of just direct patient care. Please join us next month. And excuse me. Thank you, everyone. And look forward, and you'll see will be there by February 5th.
Thank you, guys.
Thank you so much.